Hey, welcome to this pharmacology drug class review in the category of anti-diabetic drugs with a specific focus on the Biguanides. This drug class is part of many other drug classes in this large category of medications that give us as clinicians cost-effective options in the management of type 2 diabetes. In fact, in my 30 years of practicing as a nurse, a pharmacist, and a physician, the Biguanides have been a major part of my own medical education, even in my current practice as an emergency medicine physician. And with that, I'm Dr. Busti. Thanks for joining me on This Is Why, a show dedicated to helping us as healthcare professionals understand the why behind pharmacology and the drugs that we use every day. Because when we understand the why, the how becomes easier and mechanisms start to really predict that therapeutic effect. Also helps us understand side effects, sometimes monitoring parameters and those counseling points. Now, with all of my drug class reviews, I cover core content first, and then I kind of integrate clinical knowledge and application throughout and build on it towards the end. So we're going to hit our agents, what drugs make up the drug class, common indications, uses, net benefit, like why is this drug class something that we would use, where is its value point and the overall perspective of other agents. And then we dive a little bit into the pharmacology mechanisms, and then of course go that clinical knowledge and then wrap things up. So let's start off talking about the agents. Well, thank goodness, like some of the other drug classes in anti-diabetic category, there's only one drug class or drug in this class, and that's Metformin. Now, Metformin, there used to be another one called Phenformin that was removed from the market. It hasn't been around for a long time in the United States. I think it's still potentially available in some parts of the world, but you're not going to probably see it unless somebody gets it from one of those areas. But it comes also in multiple dosage formulations. There's an immediate release, extended release that gives us some tailored drug therapy options for our patients. People tend to tolerate, you'll see, better the extended release, right? But then there's also other combination therapies with a lot of different medications. And that tells you something. When you see Metformin combined with other drug classes in particular, you're not only trying to improve compliance and adherence, but maximizing the overall clinical effect and desired therapeutic outcome in those patients. Okay, now let's move over to our indications and common uses in clinical practice. Now, this is predominantly for patients with type 2 diabetes, and the management in conjunction with, this is important, I'm going to keep bringing this up, diet and exercise. So medical nutrition therapy, MNT, and exercise are absolutely the first line, whether you're treating type 1 or type 2. Other common uses where we see it, and it's pretty long, patients with antipsychotic induced weight gain that then predispose them to metabolic syndrome, insulin resistance, prediabetes, and then eventually to diabetes. I mean, that's pretty common. Gestational diabetes, so around pregnancy, polycystic ovarian syndrome or dysfunction, okay, PCOS, and then obviously also for prediabetes, okay, and that goes back to some of the mechanisms and how it works. Now let's jump into the net benefit. Why grab this drug and use it in the context of other agents that are available? Well, one is its history, man. I mean, it's been around for a long time. You've got evidence with clinical trials, you've got history and that experience that gives us what we want and need. Yes, there's some nuances with it, but quite honestly, it's a pretty cost-effective drug therapy that lowers the A1C by up to 2% without facilitating beta cell burnout, which essentially worsens the progression of the type 2 diabetes, like our secretagogue drugs are known to do. Things like Gluconeogenesis, sulfonylureas being the secretagogues. I'll talk about that here in a minute. Now, so when you can lower the A1C without worsening the progression of the disease, and you offer patients weight loss, you can improve their lipids, you have a low risk in most patients, not all, but a low risk for hypoglycemia, and very limited drug interactions. I mean, you're checking a lot of boxes there that make it clinician and user-friendly, even for patients, right? All right, now we're going to move into the pharmacology, where we start diving into mechanisms, what's the main effect, and then we'll start putting that in the context of the overall place in therapy. Okay, so how does it mainly work? Well, there's a couple things like decreases in insulin resistance, maybe some impact on intestinal absorption of glucose, but the main primary dominant effect is reducing excessive hepatic glucose production, basically also known as hepatogluconeogenesis. So the hepatic output of glucose predominantly from the storage form of glucose, which is glycogen, right? So its predominant effect is on this excessive amount. Remember, so we, normal patients, maybe right here, and a patient with type 2 diabetes is putting out glucose from the liver up here. And so when you give this drug, you're just bringing them closer back to the normal. And that's why the risk of hypoglycemia is low, because you're not really dropping them. You're just bringing them back to a closer to a normal level in particular. Now, you'd have to fast significantly, and you would have to drink alcoholic with poor glycogen stores in order for really to create true hypoglycemia. And I quite honestly have never seen that. In my personal experience, I've never seen that with metformin. I'm not saying it doesn't ever, there's no case reports of it. I'm just saying I've never seen it, okay? Now, mechanistically, it's complex. There's been a lot of debate about the exact mechanisms. How does it affect hepatic gluconeogenesis? All those things. Well, if you look inside kind of what's going on in the liver in particular, we have glycogen over here. And glycogen is that storage form of glucose. So we can form, the excessive amount of glucose that we bring in will replenish it and give us the storage forms that we need. And then when we go through periods of fasting in between the meals, that's when our liver is trying to help regulate the blood sugars to maintain glucose homeostasis. So we have this constant balance of insulin and glucagon and the hepatic gluconeogenesis and muscle's contribution of glucose as well to keep basically the body in a certain range. The body does not like extremes, right? Balance is key. So that glycogen gets converted eventually to glucose 1-phosphate, and then it gets converted to glucose 6-phosphate, where eventually through glucose 6-phosphatase, this enzyme, is what converts it to glucose and puts it into this blood or circulation for us to use. Well, metformin has a negative inhibition or feedback on that particular enzyme pathway. So this pathway that's predominant here is decreased. Okay? Over here, there's also conversions from pyruvate through a very complicated biochemistry process that I'm not going to dive into in the details here because it's quite honestly, it's important, but it's not testable. You just need to recognize that the mechanism is affecting multiple enzymes, that the net overall effect, because both of these arrive at the same location, the net overall effect here is that we are impacting the overall output conversion of glucose 6-phosphate to glucose in the blood. And that's predominantly happening in the liver. And that is the main mechanism, which typically happens in that fasting phase. Okay? And so that explains why, again, going back, that it has a lower risk of hypoglycemia, because we're just bringing excessive down to less excessive. Now, from a pharmacokinetics and dynamic standpoint, metformin is not metabolized in the liver. You're going to hear about lactic acid levels and lactic acidosis risk. Lactate production and things like that, metabolism is impacted in the liver, but metformin is renally eliminated. And so, of course, based on that, there is required renal dose adjustments and avoidance in patients with pretty severe CKD because of the risk of lactate. And that's really where Phenformin was removed. I never saw Phenformin in my clinical practice, even though I've been practicing for 30 years. I've never seen it. Read about it, heard about it. I've read and learned. I've been beat to a pulp about Metformin throughout my life in nursing, pharmacy, and medicine, and I've never once in my entire career, ever seen Metformin-induced lactic acidosis. I mean, I'm not saying it can't happen. I've just never seen it. Okay, so I'm not saying that means you ignore it. There are people that have greater risk factors for that. Obviously, people with significant renal impairment. And may be influencing the overall levels of lactate in the body. All right, now we're going to transition over into that clinical knowledge, the pearls, and we're going to step into kind of the application, the management of patients with type 2 diabetes in particular. Where is the place in therapy? Now, I've already kind of alluded to that a little bit, but let's codify it in the context of guidelines, but also other available drugs in the anti-diabetic arsenal. All right, so metformin is still a potential, and I say potential, it used to be the recommended first-line therapy, again, in addition to medical nutrition therapy and exercise, okay? But it's always been historically one of those first-line, front-line agents because of its history, because of the evidence, and because of the ability to lower the A1C by 2% without worsening the progression of the disease by causing beta cell burnout. Okay? Now, obviously, the evolution of other anti-diabetic drug classes that target the underlying causes many times of diabetes, the GIP, GLP-1s, GLP-1 receptor agonists, those agents, SGLT2 inhibitors, all those things that have evolved that also don't cause beta cell burnout and also help you lose weight. Those drugs have gained a lot of momentum and steam and also have supporting evidence behind them. So obviously, you know, drugs that show up that are new on the market or newer and new data and all this expansion, some of these older drugs that are now generically available get shuffled away like they don't exist anymore. Well, the reality is metformin is still a very feasible option for patients. It's a cost-effective option. And you should consider it in patients in either first-line monotherapy or in combination with other medicines, which is, again, goes back to those combination therapies that I was talking about before. So I try to summarize these big sort of pictures about the management of diabetes and the drug classes we have in tables. I think it's good to wrap your mind around the big picture. Yes, you can dive into the minutia of the guidelines and every little nitpicky decision. The reality, this disease continues to evolve, and it will continue to evolve. They update the guidelines every year. There's always new stuff coming out, but there is a general theme that, quite honestly, for several decades, has largely not changed, right? So some of these new designer drugs help us, and they codify things, and they allow for tighter control, and they get to root causes. I'm not minimizing them, but there's a general message. So you have type 1, type 2 diabetes in this table. And again, these tables are available at thisiswhy.health for you for free download, right? There's other playlists, collections, coupons that we provide for partner organizations if you need board exam reviews, stuff like that, that you get for free. So, you know, feel free to go there, download these. The link is available in the description of this episode, whether you're on YouTube or on our podcast channels. You can access that page from there, okay? So type 1, type 2 diabetes, you see the very first thing is that, again, medical nutrition therapy and exercise. I will never stop talking about that. We should always treat the underlying problems and take care of the patient comprehensively. Then you see with type 1, obviously, that's insulin plus or minus pramlintide. So that's not really where we're at here. We're really over here in this type 2 row or bucket, where you start out with monotherapy, and that can be metformin, okay? Or in combination with a non-insulin-based regimen. Why avoid insulin? Well, we don't want, insulin typically causes people to gain weight. So if we can avoid that, that's going to help avoid insulin resistance and other things. And you see that if that combination therapy fails, or if the monotherapy is not working to get them to goal, you don't want to sit around for years trying to get them to goal, where they develop, you know, diabetic nephropathy, diabetic retinopathy, and you got neuropathies, and all these things, cardiovascular disease is progressing. We want to get to aggressive, and sometimes you have to go to insulin, especially if the glucose is too high. Because many of these drugs, these agents will not get people to goal by themselves. And if your maximum around is 2 to 2.5%, and if you follow diet and exercise and max treatments, well, if your A1C is already at 11 or 12, you're not going to get to less than 7. That's not going to happen. So you may need to start out with insulin and then tweak them. There's more than one way to manage patients. All I'm simply telling you is this is kind of where the metformin sort of fits in that bullet right there, okay? Now, as we go through the anti-diabetic medications and drugs and the classes that make them up, we have two big categories. We have the secretagogues and non-secretagogues. And secretagogues are going to be drugs that facilitate the release of insulin from the pancreas and beta islet cells, and that's your meglitinides and your sulfonylureas. Okay, so you can use metformin in combination with these drugs, and historically that's what was done, historically. And then we have the non-secretagogues. Going back to the secretagogues, the problem with those is that they're going to cause beta cell burnout. They're going to facilitate the progression of type 2 diabetes. Whereas the non-secretagogue, non-insulin-based regimens here, they are not going to cause beta cell burnout. They have typically, many of them have options for weight loss, and they treat other aspects of the disease, including postprandial. Okay, but our metformin or biguanides is right here, and I try to put the mechanisms for each of these subclasses side by side so you can sort of study them and see what is the difference and how do those differences and why do those differences translate to the effects. As you begin to learn and memorize these facts, when you understand why that matters, then it's easier to retain it and see these differences for what they mean clinically. And so I only have metformin listed here. Phenformin is not, like I said, because of its removal from the market. Now, what about comorbidities or things? Again, we're in the context of place in therapy. So when would we try to use metformin in maybe certain people with certain comorbidities and try to avoid it? Well, I hope I've already kind of laid the groundwork for some of that already. On the left-hand side of this table, again, you can get this at thisiswhy.health. You see that we have the different conditions: overweight or obesity. We have dyslipidemia, CKD or renal impairment, heart failure, coronary disease or atherosclerotic cardiovascular disease, gastroparesis, IBD, which is inflammatory bowel disorder, IBS, pancreatitis, osteoporosis, and even thyroid C-cell tumors, where we see that in our GLP-1 receptor agonist group, okay, as a concern. Well, metformin, and when you think about when you would consider it, like when should you try? Well, remember, it causes a little bit of weight loss, so metformin would be one to consider. You see other options there to consider as well. Your GLP-1 receptor agonist, DPP-4 inhibitors, SGLT2 inhibitors. If you have dyslipidemia, I said that earlier, that was part of our net benefit. It does improve the lipid profile. So those are very helpful main reasons why we would try to use them if those comorbidities exist. What about when we would avoid them, right? That's that last column. You see over here, patients with renal impairment, CKD, we're going to talk about the dosing of that here in just a minute in more detail. But that's a reminder of that, especially in patients with an acute kidney injury or, acute renal failure, but acute kidney injury is a more accurate term. You see with heart failure, it says plus or minus. And I use the word if hospitalized. Because in general, there's nothing wrong with using, there used to be a concern that low cardiac output, low stroke volumes in heart failures, especially with reduced EF, those patients have reduced blood flow to the kidney, which then theoretically would increase the accumulation of the drug in the body. And there's truth to that. I'm not saying that's wrong thinking. It's just that the evidence doesn't say that it's really harmful in patients that are otherwise stable. However, in acute decompensated heart failure and they're hospitalized, there is a greater risk of hypoperfusion and acute kidney injury secondary because the heart or the pump is not adequately perfusing the kidney. And so that's where it says, yeah, maybe just be aware of that concern in that specific scenario. All right, so moving on to dosing considerations. Again, this is that clinical application, the clinical pearls, especially if you're new to this. If you're an expert, you know this already. Sorry, I don't mean to insult anybody's intelligence here. That's not the goal. I'm trying to make sure that we all, as healthcare providers, the whole team knows this and understands it so we can all work together to effectively manage our patients. So Metformin, remember it came in multiple dosage formulations, combination, but also immediate release and extended release. But you need to titrate the dose for tolerability, okay? And so there's a titration recommendation that you can see there over the period of 2 weeks in particular. And you're trying to get there, and you do that to reduce the GI side effects. And I've heard patients say they stopped taking it because of the GI side effects, probably because somebody was too aggressive and did not talk to them and counsel them, and so they just pushed it away, rejected it, right? And many times we just talk to the patient and they're aware of it, it's not near as concerning to them, and they're more willing to tolerate it, because if you continue the drug appropriately and you go through the titration, the patients tend to tolerate it well. And quite honestly, having a little bit of loose stool is not a bad thing, especially in patients with diabetes, because they can develop gastroparesis. We also have these patients who develop constipation. I mean, I see a lot of constipation in the public. I mean, it's crazy how many people come in the emergency department with constipation. Well, that sets people up with risk of diverticulosis that can lead to diverticulitis. It just causes more abdominal pain syndromes. We don't need that kind of stuff. So this can be good. Now the max effective dose down here at the bottom, max effective dose is 2,000 milligrams. So pushing the dose higher, which you can go higher technically, the bang for the buck is very, very small when you exceed 2,000 milligrams, regardless of the dosage formulation that you are using. But most people are going to tolerate the extended release much better than the immediate release. All right, renal dose adjustments for metformin, okay? I told you that earlier, that it's not metabolized in the liver, it is renally eliminated, right? And so patients with CKD or acute kidney injury, we need to be careful. The risk of lactic acidosis, theoretically there. So you should memorize these GFR cutoffs, okay? Now, if patients are kind of in that bubble of the 45 to 60 window, there's really no major recommendations. But once they drop below 45 and they get in that 30 to 45 window, then you probably need to err on lower doses if they've already been on it. Some people even recommend that if you're trying to start it, and they're already at that window, that you consider bypassing it and go to something else, okay? And then certainly once you are below 30, the general recommendation for board exams, the error on the side of legalities and clinical practice, is that you should probably try to just avoid it. Now, if they've been on it, they're stabilized, they're not having any problems, and they're effectively controlled, then obviously you have that shared decision-making conversation with the patient. So I've kind of beat up this concept of lactic acidosis, and again, I told you it's rare. It is very rare. So what does it look like? Well, you see an anion gap metabolic acidosis pattern on your labs. The symptoms are very non-specific. They just feel fatigued, myalgias, maybe some respiratory distress, abdominal pain. It's just like you wouldn't be able to go, oh, I think you have lactic acidosis. Like, you need labs typically and a history, the metformin, something's wrong. You measure the lactate levels, lactic acid levels, and you sort of see what's going on, right? But so who are these people that are at risk? Well, patients with renal or hepatic dysfunction, they're going to be at higher risk. Patients taking other drugs that could theoretically raise that. We know that certain drugs like aspirin at high doses can impair the electron transport chain and things like that, and can cause risk of acidosis. Older patients over 65, radiographic studies that involve contrast, kind of talk about that. That's also pretty rare, but again, it's the potential. The potential is there. Patients with excessive amounts of surgeries and alcohol use, hypoxic states, acute heart failure with decompensation, those kind of things. Now, I want to take a moment to talk to you about Phenformin. Remember, I brought that up a little bit ago, at the beginning. It's a drug that's just gone. It was back in the market 1970s, right? But it was pulled off after the concern of lactic acidosis, and it just never came back. Obviously, the risk of Metformin is much less, so it stayed on. But I wanted you to recognize that that drug was the culprit that created the black cloud that hangs over this class, and it quite honestly hasn't changed. And so Phenformin, Phe and Formin, you can look it up. Again, different parts of the world, I've heard that it's still technically available in some parts. I personally have never seen it. But I just want to make sure I paused and really clarify that statement in the context of this conversation. Okay, moving back to the kidney issues with radiographic imaging where we're using iodinated contrast dye. So we put an IV in, we use contrast solution to basically light up the blood vessels. There have been concerns historically, especially with older formulations and things like that, where we didn't also hydrate patients, of some acute kidney injuries. And so if patients, the historical teaching is that if patients were already on Metformin and they come into the hospital or the emergency department and they need to have a radiographic study with a contrast, that we would typically stop the drug and hold it for approximately 48 hours after the procedure to make sure that nothing happened. I have never seen acute kidney injury from IV contrast. Personally, I've just never, in 30 years, I've just never seen it. Again, I'm not saying it doesn't exist. I'm not saying it's never happened. I've seen people have allergic reactions to it. That I've seen, okay? But I have not seen acute kidney injury in traditional everyday use in clinical practice. Now, many times, again, people are adequately hydrated. We manage these patients appropriately. You don't see it, all right? They're not on other nephrotoxic drugs around it. But again, if you're concerned or there's a high risk, then just hold back off, on that. All right, so from an adverse effects standpoint, your GI side effects, those loose stools, is a problem for some patients. Counsel them. Use extended release. Titrate appropriately. That's how you minimize that. So you maximize compliance adherence. Weight loss. That's not bad in a patient with type 2 diabetes. Now, is it the same amount as a GLP-1 receptor? No, but it's still better than nothing. And remember, you also improve the lipid profile, so that's something that you can benefit from. Now, hypoglycemia is really not a significant risk because, again, remember, we're bringing excessive just down close to normal. You would still have to go lower than that to get hypoglycemia, but where patients get it are with periods of prolonged, severe, fasting, where their glycogen stores are compromised. From a monitoring standpoint, the A1C clearly is one of those things that we're going to monitor. Again, you can see up to 2%. That's what the evidence shows with this drug. And so you want to get baseline levels, and then, in three months, you want to make sure that we're moving in the right direction. If not, you need to add on additional treatment if you're using it as monotherapy. Renal function, checking that serum creatinine. And then vitamin B12's levels are also being pushed more. Metformin has been associated with lower levels. And vitamin B12, while it's a hydrophilic water-soluble vitamin, part of our B complex vitamins, when you're deficient in it, it can cause nerve problems. And patients with diabetes already have nerve or neuropathy issues, so we don't need to exacerbate that. And you want to adequately replenish that appropriately. So if they don't have the ability to absorb it from the GI tract, then give it parenterally. All right, so counseling points, titration, appropriate dose, those side effects on the GI side, and then the importance of compliance, adherence. All those things are huge. Okay, so the Biguanides, Metformin, it's been around for a long time. Good history. Indications for type 2 diabetes predominantly, but don't forget about those other uses. Antipsychotic induced weight gain gestational diabetes, PCOS, and prediabetes. Remember, it's working on that hepatic gluconeogenesis. That's the output of the glucose from the liver. So it converts that glycogen to glucose. May have some impact on insulin sensitivity, absorption. Like those are probably related to weight loss and the side effects of the GI. So just counsel those. Look for those side effects and those monitoring parameters. Monitor that serum creatinine. Monitor their A1C. Make sure they're achieving their goals. Remember, if you can only get 2% and they're at A1C of 10, 11, 12%, they're not going to get there on Metformin. I mean, I like the drug. I think it's great. I think it has a lot of value and benefit, and it's cost effective compared to other drugs. So it's not a benign medicine, you should use it, but it's not going to get that person to goal. So you do have to consider its limitations, just like all the drugs in the anti-diabetic arsenal have limitations and side effects, okay? All right, well, I hope that you found that to be really helpful in putting it in the context of the management of patients with type 2 diabetes. Please join us on YouTube. If you haven't done so, subscribe, give us a like. We really appreciate that. Ring the bell. That kind of gets you alerts to when new content comes out so you can stay up to date on various topics. If there's a topic that you're interested in or a clinical question you want me to try to answer, shoot over to thisiswhy.health. We offer free sign up. You get access to these tables, images, playlists, collections, discounts, other things. That's all there for you. It's an investment in what we're doing, what you're doing. And so thank you for joining me. I'm Dr. Busti. Never stop learning the why behind what you do, because it makes the how so much easier. You don't have to rely on memory. All right, take care, guys. See you next time.